What's up, nurses? Welcome back to the podcast. I'm your host, Kati, Kleber, and today we've got a great interview to share with you. This interview is with Jennifer Flynn. She is the Vice President of Risk Management for NSO, the Nurses Service Organization, in the Healthcare Division of Aon Affinity Insurance's Service. So she's worked in risk management and healthcare insurance for over 24 years, national speaker on healthcare risk and liability. She's a published author on risk management, and she's certified in professional healthcare risk management and licensed property and casualty agent. Boom. A little bit of an expert here. Expert alert, people. Very excited to share this with you. I've talked about with a nurse attorney. I talked about the aspect of the importance of liability insurance, the pros and cons and things to consider. Never actually talked to someone who's worked in the industry, let alone an expert on this level. So I'm very excited to share this interview. Expect to learn things like the differences between employer-based insurance versus individual, practical ways you can reduce your risk for litigation, some of the most common situations in which nurses need to use their liability coverage, and a whole lot more. Buckle up, guys. It's a great episode. Let's get into it. Jennifer, welcome to the podcast. I'm so excited to chat with you.
Thank you. Yes. Thanks for having me.
So I wanted to jump in and ask you about common situations in which nurses would be using this insurance. So I know we tend to go to the extremes, like the Rhadonda Vaught case, and we think that's the common situation, but that's really extremely not common. What would, when nurses are filing claims and saying, hey, I need my insurance, what is the run-of-the-mill hospital nurse, let's say specifically a nurse working maybe in a hospital, why are they needing their insurance?
Yeah, definitely. So, it's so hard to answer that question, and yet we have data. So let me just take a step back, because really each claim is based on its unique set and circumstances. And every claim that we see, while it might have an underlying factor, right? The what failed and why. Was it a breakdown in communication? Was it a clinical misstep? All of those things all come into play, definitely in a liability lawsuit. But when we look at the most common types of claims, for registered nurses, they are typically related to treatment and care, right? So these aren't situations where everything goes right from start to finish. It's something that happens along the way of that treatment and care. Maybe it was an actual patient injury. Maybe it was an outcome that had some clinical significance, change in condition that would require reassessment, monitoring. Maybe it was a result that was different from an anticipated result, or the whole situation presented a unique safety crisis that needed to be addressed. These are the types of situations that fall into that category of treatment and care, that somewhere along the way, there was a change that needed to be addressed, escalating the care, chain of command, following physician orders or practitioner orders, because that change of care has been addressed, and was it done in a timely manner? So all of these situations are typical. Second to that, we also see claims involving, the Rhadonda Vaught case. While it was a very extreme case, medication administration claims are in our top 3. So we do see claims where the administration of the medication, something went wrong. Was it a wrong dose? Was it a wrong drug that was given to a wrong patient? Was the medication contraindicated to their current list? And there's a breakdown in communication there. Because we've seen some frequency and severity with these medication administration errors, we took a deeper dive and found that in order for that nurse to make the medication administration error in the beginning, they had to bypass some sort of control to do so. We have been analyzing claims against nurses for, 20 years now, and we saw a dip in medication administration claims maybe back in 2010, 2015. And that was a direct result of the advancement of technology, computer order entry systems, barcoding, and the like. So the frequency of those errors went down. In recent years, we're seeing a slight uptick to that number. And the severity or the financial impact of these claims is quite severe because picture this, a plaintiff's attorney, the injured third party's attorney is saying, if you were faced with an alert that popped up, and why did you bypass it? Why did you make those decisions along the way to have that error happen in the first place? It's not a simple answer. Going back to your Rhadonda Vaught example, yes, there were bypasses of controls there, but it was commonplace at the facility. It was really a harrowing experience that could happen to any nurse at any facility across the US because nurses realize that in order to get the medication to the patient, there might be a workaround that's accepted practice at their facility. But when it comes to an injury that the patient is injured, then those sort of outside of practices come to the forefront. And the question of why did it happen in the first place? That's the defense that we need to build for these nurses. And they become hard to defend when we see bypassing of controls that are put in place for patient safety to begin with.
Yeah, like when we get to the point of physically giving the med, it's like the provider ordered it, the pharmacist checked it, and then you scan to make sure it's the right patient and the right med order. Yeah, at this point, because I started my nursing career in 2010, actually, and that was right when barcoding was then becoming extremely common, and all the experienced nurses at that point had not had that as a constant, obviously, in their career. So it does, I could see significantly drop, but then I could see as a profession, we are acclimated to that, and the workarounds and the whatever, we bump up a bit. That is interesting. So trying to think so when you have like a nurse who has, let's go with that example, medication error, and something negative happened to the patient. Let's say they gave a med, and it was a med that the patient, here's one, got a good example. You had a patient who come in with an emergency that had to get intubated, sedated in the emergency department, goes up to the ICU. And you're giving emergent care. The patient, you don't know a lot about them because they came in and were basically unconscious. And you give them the meds that are appropriate for this situation, and come to find out the patient had an allergy to something like lisinopril that was not known to the medical team.
Not known. Okay.
At the time. But the nurse, it's ordered by the physician, checked by the pharmacist, nurse gives it. And the patient, very allergic to it, has like angioedema, that kind of thing. And the family and the patient decide to sue for that. How does that even, how does a nurse even find out I'm being sued? And it's such an unknown that if you haven't gone through it yourself, you would not know exactly how do I know I'm being sued? What do I even do? Whether or not I have insurance. And now I can imagine when you're a nurse just trying to do the right thing, that just feels awful.
Yeah.
Can you walk me through that process, just generally, start to finish?
Yeah. Well, so understanding how nurses get involved in these liability lawsuits really comes down to the definition of malpractice first. It's a type of professional negligence when the nurse either doesn't meet the standard of care or deviates from standard of
Same.
care to have subsequently caused injury or harm to the patient. In a court, though, the nurse has and their attorney have to defend themselves against these four elements that the patient or the injured third party and their attorney will bring up. It's your duty to the patient, a breach of that duty, that breach was the direct or contributing factor to the harm that the patient suffered. So when a nurse is named in a liability lawsuit, they do receive some legal paperwork. They're served. Usually there's a quick turnaround time on responding to that claim. So the patient alleges certain things happened. The nurse failed to do X, Y, and Z. And then the nurse gets to respond with the help of their attorney to say, here's my version of events, right? Against those allegations that are brought forth. The thing is that patients don't really know about that duty, breach, cause, and harm. It's more of that if they've suffered an injury, it's the perception of wrongdoing. Maybe they're asking questions about their injury that either the nurse doesn't know the answer to, or like in your case, the example that you gave, if the nurse didn't realize there was an allergy, and the patient is asking a question, maybe the nurse doesn't know the answer at that time. Maybe the facility doesn't want the nurse to answer. That might be by way of their policies and procedures. And so you're left with the patient asking you questions that you may come across evasive to them or not knowledgeable about your treatment and care, your standard or duty to them. So in those cases, that's where, having an attorney to sit there and work with you and to remind you of the treatment and care that you did provide, remind you of, what you did for that patient. These cases they don't happen quickly either. There might be in a state something called the statute of limitations, which simply put is the time that a patient, upon discovery of their injury, has to bring the liability lawsuit. In most states, it's 2 years. It could be longer for a pediatric patient, but for most states, for an adult patient, 2 years. But think about it this way. It's an additional 1 to 2 years to litigate that claim where you actually might be sitting under oath testifying and answering questions, challenging questions about the treatment and care that you provided to a patient 4 or 5 years ago. So we always talk about documentation being a key factor. The record there is what's going to remind you. Your good documentation about the treatment and care that you did provide. In the record is going to be found, what did you know about that patient and when? Right? With the advent of the electronic record, you really we've seen that these cases, all of the decisions made and the actions taken are time stamped. When you go into that record, what pages you viewed while in the record, what information about the patient was available to you, what physician or practitioner orders were available to you. How, when you implemented those orders, how did the patient respond? Did it meet standard of care and why? If it didn't, and why? So a lot of these cases take a long time. They're critical to, the treatment and care that you did provide. You'll be answering questions about something that happened maybe quite a while back. And the reminder for you is going to be found in your notes. The documentation record is not just to guard against miscommunication between other providers working on that patient, but it's to guard against a lengthy legal process. If you can prove, you've probably heard the old adage, not documented, not done. But if you can prove that you provided that treatment and care, it's supported by what's in the record, you can answer questions about your clinical decision-making rationale to have made that decision in the first place. Typically, those are the cases where we have a good basis for a defense.
I have a quick question
Yeah.
about that, because I have done, and I've observed, where nurses will copy and paste their rounding on the hour for all of their patients, and copy and paste something that they did earlier, but they're not going in the room again. And if you look at like their 5 patients, it says or the documentation that they were in 5 rooms at the exact same time. Or like you see like an ICU patient who has an assessment documented per policy, but it's on the hour every hour. And it's like, were you really in there at that time? Can I try, like, can you really, like, if people are doing that, like, and it makes the chart look very nice and it looks great.
Yeah.
Is that wise? Like, I've had people say, I've been told to just copy and paste on the hour every hour. And then I have other people say, and I know, like, I've known policy where you're supposed to document it when you go in, not a pretty whatever. And then you have other people say, I was taught differently. What's the right answer? And it's like, well, my assumption is you just document when you actually went in there. But I'm curious, when we get to a point of a litigation and you're like, okay, when was the nurse in the room? Oh, they were in the room every single hour at the exact same time, but they had another critically ill patient. How is that possible?
Yeah. We would say no to that. we would say, be careful. And because of the reasons for this electronic record, we know that copying and pasting is a time saver, right?
Okay.
And it's not, it is an accepted practice. So we realize that. But what nurses have to realize is that they are signing to that record the actions that they took. And anything outside of, if it is not a complete and accurate record, could be misconstrued as fraudulent, right? Those actions are used for billing. Those actions are used to provide testimony that you did what you said you did with the patient. If we looked in the electronic record and seeing everything being time-stamped and knowing that a nurse can't be in 2 places at one time, that is going to weaken the nurse's credibility when they have to go then and defend their actions. But that electronic trail, that audit trail, or the metadata, the data behind the data in that record, the plaintiff's attorney has access to that as well. So they will absolutely poke holes in the statement of the nurse, poke holes in the version that the nurse will tell related to what's found in the record. And it's done so that a jury can understand, if we can't trust the nurse's version of events, they're going to trust the plaintiff's version of events. And then it will come down to, what happened to the patient as part of their injury. What is the financial impact of that injury? I think what is very important to understand in liability cases is that probably 9 times out of 10, those records that you're copying and pasting, that nothing happens to that patient. It's the time that we're talking about when there is an injury, when they go back to research what led to that injury, when the patient can prove that prior to that injury, They were able to enjoy, a certain level of activity of life, a certain happiness of life that they're no longer able to enjoy as a result of that injury. So after the injury, and they're going to sue for all of the monetary compensation that emotion and bills and everything that comes to play with that injury represented in their life. So that's why these cases can vary widely in terms of the payments that are made, um, the injury that befell the patient, what that injury represented to the patient in their life and the financial impact of that, as well as what they can prove. So if the credibility is weakened of the nurse, if the defense is weakened, if the jury is going to understand that the plaintiff's version of events is more likely to have occurred, we're going to see allegations of negligence being proven in these cases.
And you said jury. How often do we get to like a jury trial, or are the majority of them settled before we get to that point?
Yeah. Our records indicate that those cases that go to jury trials are actually the lower likelihood. Usually along the way, there are allegations brought against the nurse. We look at those allegations and try and get the nurse dismissed from the case based on what we can prove through the documentation. If the documentation is weakened, then we might say, okay, does the nurse have any percentage of liability? And that's based on, there's a misperception that you're either 100% liable for a claim or 0% liable, when in fact there's shades of liability. I've seen cases where the nurse, it was attributed 30% of the liability or 50% of the liability based on their actions or failure to act, based on what's in the record, what we can prove, and how the patient responded. And so, if we can't get the nurse dismissed from the case, and it does look like some sort of liability will be attributed to the nurse, it really depends on, behind the scenes, what kind of communications are happening about that case. If the defense is strong, we're going to fight for that nurse to all the way through. And have cases that resolve in 2 years, 3 years, 5 years. It could be a long experience. If we know that there have been some missteps along the way, and we can also see negligence being attributed to the nurse, we will try and settle that case, just to have the situation end and resolve the case for the nurse. So, but going to a jury, to your question, that's the last step that would happen, and it's more likely that these cases will be settled before going to a jury trial.
That's interesting that you say you're right. My brain does go to, you're either 100% responsible or not. But then if going back to that original example of like the lisinopril, well, yeah, like, yes, the nurse gave it, but the physician ordered it, the pharmacist checked it, or whatever. And, and I would probably, unless the nurse went and grabbed the wrong med and didn't scan it and just gave it. I mean, how else could it not involve somebody else, like the person who ordered it and the pharmacist at minimum, right? Like, how often do you really see a nurse that's the only person who did something wrong? Like, I would assume, my guess is that would be probably a rare case. But maybe I'm wrong.
Yeah, in these cases, we see, everyone involved in the treatment of care of that patient being named in the liability lawsuit. And again, it's to what extent did their actions contribute or cause the injury? So in that case, could it have been that the nurse didn't get a complete history and current, medication list, asking those questions about their allergies? Could it have been that, it wasn't in the record because somewhere along the way it didn't get, asked if even if the nurse wasn't responsible for that, or that the physician ordered that, not realizing there was an allergy. So it really depends on those unique facts and circumstances of the case, and what did you know about that patient, but what should you have known about that patient,
Sure.
right? Before, we talk about nurses and medication. Nurses are the gatekeepers of, that last line of defense before that patient gets that medication. And we see in facilities there's a lot of distractions around that process. There is some miscommunication about what they can access, in the cabinets and the machines that deliver the medications. There could be a breakdown, like you said, in the delivery of that medication by way of not following policy and procedure, not scanning, not double checking that two item identifier with the patient, and so all of these facts will come into play on whether or not the nurse is found negligent based on what would have been a standard of care, and how the nurse's actions met or exceeded that standard of care or fell below it.
So what's like the difference between standard of care and culture at a hospital? So like standard of care would be like scan twice, or I'm sorry, like you don't bypass the alerts and you always do the double check. But like what if your hospital just always overrides and that's just what we do? Like when would a nurse be held responsible, even, because if you have like an unsafe culture, but everybody just accepts it and just does it, and then something bad happens,
That
like,
still doesn't make it right, but
right,
yeah, yes.
right. Like I don't want it to get
Yeah,
explained where it's like, this is just our culture and we do it. And I can understand like when you do have a situation where that darn Pyxis machine has this thing where it's not populating our patients appropriately, so we can't get meds unless we just type in the med. But then there goes a safety check, and then that
yeah.
doesn't get addressed. And then we've lost a safety check, and then something else happens, and we just give them, uh-oh, something really bad happened. Um, I guess, yeah, like I wonder when you can't explain away the actions when you have a already, like you have an unsafe unit. I don't know. I don't even know if I'm asking a clear question.
Well, so I think what you're also asking is, the nurse is responsible. Yes, culture is part of leadership, part of implementing, policies and procedures. At the nurse's level, they are tasked with following those policies and procedures, speaking up when they see a safety issue arising so that it can be remedied. But at the end of the day, the nurse is responsible for their actions regarding that patient. So standard of care is not it. It doesn't necessarily take into account culture, although that could be a part of the defense. But standard of care, very simply put, is what would a reasonably prudent person have done in this same or similar situation? And it's related to clinical care, not so much the culture, but your clinical standard, your actions that meet what another nurse would have done in your area, in your state, in your specialty. So standard of care brings into account, not just the education, the training, the background of the nurse, and their experience, not just the how that patient is presenting and what they know about that patient, the history, their condition, any changes to that. But it also brings into account what professional guidance or other providers would do in that same situation. So are there, um, you know, items that have been proven to meet standard of care or patient safety goals? Are there evidence-based practices that are proven to reduce the likelihood of an incident? And so it applies to those situations, current guidelines, accepted practices, what professional associations and networks say about, what that nurse should have done. But it has to be supported by an expert testimony. So another nurse coming in and saying, yes, I would have taken the same exact steps. And so they're supportive of the care and treatment that you provided, or they're looking through the lens of, well, no, I would have done X, Y, and Z differently. And so they might be critical of some of the steps that you took. So in your example of, um, bypassing controls, that would be a critique. In your example of copying, pasting, and not reviewing that record for accuracy and putting it into the record as complete, that would be another expert nurse would be critical of that behavior. When we're talking about culture, though, we're talking about that if a nurse suspects or sees near misses, safety crisis, or a potential safety crisis, having the ability to go to leadership and say, this is happening and we need to, try and stop it or prevent it or reduce the likelihood of it happening. That's the difference between the standard that a nurse would be held to versus having, feeling like their voice will be heard at their organization to say something to stop and prevent an injury from happening in the first place.
That kind of goes into one of my other questions for you, which was going to be, what can nurses do to mitigate their risk? And if you are working at a hospital with leadership where there is this different standard of care and or you're noticing an issue like the Pyxis thing and they don't take it seriously with a sense of urgency, like that would be probably like a, whoa, if there's only so much you can control as a bedside nurse. And if you're raising various or seeing other people raise these issues and they're not being taken seriously, at the end of the day, it is your license. And
Absolutely.
yeah, so other ways you can, like, I know we can mitigate your risk. Well, practice prudently. Okay, well, yeah. If you're listening to this podcast episode, you're probably practicing prudently, to be fair. But like, what are ways, and I'm assuming one of the ways you can mitigate risk is noticing how your leadership responds with these kinds of, when safety issues come up. Do you have any other practical ways nurses can do that?
Yeah, so the funny thing is that the recommendations that we see happening with some type of frequency in all of the claims are very simple steps. So the nurse, not knowing their scope of practice in the state or not reviewing it on an annual basis, not keeping up with the trends of their industry, right? Maybe not, if you have a documentation standard that your facility likes to keep and that you've attested to understanding and knowing the policies and procedures at your facility, not following them. So understanding facility policy and procedure against your scope. If scope is vague or missing, you should always defer to the standard most stringent for what you're doing, right? So if your facility policy is more stringent than your state, then you should be deferring to your facility policy. You don't want to be left with the facility saying you didn't follow our policy and procedure, though you attested to knowing it and understanding it. And that's what caused the harm to the patient, because might not only get you involved in a liability lawsuit, but might get you even dismissed from your employment on top of it. One of the things we talk about very simply is maintaining clinical competencies. So that is going to industry conferences, being aware of evidence-based practices that are coming out, and how that might even change your clinical view of that patient. Talking about in today's day and age, we have nurses working with patient populations that might be specific to their facility. So if you're working in a pediatric practice, or if you're working in a behavioral health center, or if you're working in labor and delivery, being aware that there are specialized populations that might have unique facts and circumstances about that. In our data set, when we look at claims that have a high severity, it's related to these patient populations that when there is an injury, the cases become very sympathetic. The patient might be described as vulnerable, at risk, compromised. And so, starting off with, doing that great assessment, monitoring your patient, communicating with all involved in the care, other nurses, your supervisor, the physicians or other practitioners involved in the treatment and care decisions, being the advocate for the patient. So raising those concerns up the chain of command to the point of resolution. So some of these things might be emphasized by way of your patient and how that patient is presenting to you on that day that might be new or different than how they presented to you in the past. And then, I know I keep going back to documentation, but when we want to talk factually about what's found in the record, it's what you saw, what you heard, what you observed. It is a good record is contemporaneous, meaning it's happening at the time of care. It's professionally appropriate, meaning that there are only notes in there related to your clinical decision making and not notes about any derogatory statements about the patient or the situation. Some nurses don't realize that it's not just the record, but we have cases where texting comes into play, where, the intermessage system that the facility uses comes into play if it's related to treatment and care. And if you don't want to have your notes displayed, or if you would be embarrassed to see your notes displayed on a large, monitor for all to see, then you probably shouldn't be making that note in the first place.
Let's reemphasize that, people, with your text pages and the level of professionalism with them. I really want to hone in on that, people. I know we can get very chummy with our physicians and get really, and each other. But yeah, that could easily be on a large thing in the front of a courtroom. And when you were saying that, I remembered when I worked neuro ICU, we had EEG monitoring, which included a camera and audio so that we could, someone remotely could watch the patient to see if they had visible seizure activity and correlate that with the EEG monitoring system. And I had a situation where a family member did something illegal in the room that was caught on camera, and that was obtained by law enforcement. So they're going to observe the whole thing. So it's like if I was in the room saying inappropriate things, things that you wouldn't want we should be functioning like we're being watched at work. There's a degree of professionalism that we should always maintain and not lose. And it is easy to do that, I think, with nursing when you're doing a normal part of your day is doing things that are very they're professional, but they're like not at the same time. I think nurses can get a little locker room talk a little too quickly and get pretty casual with conversation, especially with text messages and things. So
Right.
I think that is a very helpful reminder, Jen.
Yes. Well, you mentioned video, and we are seeing cases now that include a video component. And the scary part is that the attorneys might be putting that video component up against the notes in the record
I didn't even
and to
think about
show
that.
chronologically, did the documentation reflect what actually happened in the room? So
Do you
it's one of
see?
our emerging trends. We're keeping an eye on it,
Okay.
but video, you watch the news every night, you mentioned, and that's becoming what people want to expect to see, a video component. And I realize in healthcare, it's a little tricky with HIPAA privacy and all of that, but with technology, we have, video companions now. We have remote patient monitoring. We have actual surveillance security videos in certain parts of a facility. And if that is going to come into play, we want to know what's on that video and how does it affect the case.
Have you had, I mean, I just realized, if you have a situation where you have a family member who's not happy with the care that's being provided, and do you have to deal what if they're taking video with their phone that's time stamped? Like, I didn't even, when I started, there was no like, people had iPhones, I think. Oh my gosh. I don't know actually back then if they did. But like video now, like there are people taking lots of video in hospitals when they're not supposed to be necessarily, but is that stuff that is
Well, and
acceptable or
right, and to your point, it's not because of any untoward circumstances. Sometimes people will record what you're saying to them just to remember. Maybe a
yes.
family member comes in and says, "Oh, I have to remember for my mom, for my loved one, what the nurse and the staff told me," so that they want to be adherent and compliant to have the best outcome for their family member or even themselves, right? So, recording is a state by state on a state by state basis, the laws around that, do you need permission? When can you or cannot record? But certainly inadvertent video has come into play for those reasons. If someone, left the microphone on as they left the room, inadvertently left it on, and then overheard a conversation that maybe they weren't meant to hear.
Mhm.
So when we talk about, again, going back to credibility of a professional, becoming of a licensed professional, it's a higher standard.
Yes, I've heard pushback about like, well, why can't we do X, Y, and Z? And, but it's like, yeah, we are held to a higher standard, especially at our place of work. Like, I think that should be like a normal expectation that we're not going to be able to function like we do in our private lives at our place of work, especially when we have a professional license. And speaking of professional license, we've talked a lot about how this works with like a malpractice or negligence or whatever in like a civil, maybe criminal, but probably
Civil.
civil
Yep.
situation.
Mm-hmm.
Let's talk about the other side of the coin with your professional license, because you could be in a situation where maybe something bad happened. You were brought into a lawsuit. Maybe it got settled, but you could still also be held to account to your nursing board, which is a completely different thing. Um,
Absolutely.
can you chat about that a bit, with nurses not only facing responsibility to a civil situation, but to their nursing board? I think that's something nurses don't realize that
Yeah.
just because maybe a lawsuit was settled doesn't mean everything's fine. Your board could still have a problem. Like, can you maybe give us an example, chat through that a bit so people have some more context and understanding?
Yeah, yeah. So we see those state board of nursing matters come through in the program as well because there is a coverage extension for defending your license that's separate from the malpractice limit of liability. But I think what nurses have to realize, and you mentioned civil lawsuit, the malpractice events, the medical malpractice civil lawsuits are resolved through monetary compensation, right? 9 times out of 10, 99% of the time, nothing happens to the license. It's resolved monetarily, and yes, it may kick off a state board of nursing investigation. The State Board of Nursing matters are a little bit different. So if you go to any State Board of Nursing homepage, right there, their mission is to protect the public. So when they're handing over you your license to say you've met the requirements, it's done so with the responsibility that you'll provide care up to the standards and scope of your license in that state. And even though the board is there to promulgate the rules of licensure in the state, they're also there to discipline any licensee that might cause harm or have potential for harm to any, constituents in their state. And so the board matters are quite interesting because in this malpractice matters where it might be the injured third party bringing the lawsuit, the estate, if there's the deceased patient, the parents, if a minor patient, but the injury is the driving factor. In state board matters, anyone can file a complaint. Any person living in that state can file a complaint, sometimes even anonymously. So you might know who made the complaint, or you might not know who made the complaint, but you'll be served that an investigation is being launched into your license. And so the board, through their mission, will launch an investigation. They may come in and have you bring testimony, letters of support, expert witnesses. These are not informal matters. But at the end of the investigation, different from the liability lawsuit where it's a monetary exchange, the board has the authority to enact sanctions on your license that include everything from a fine or continuing education all the way up to and including license suspension, license revocation, probation, which could really hamper you practicing as a nurse, your livelihood. In these matters, we see about a third of our claims are related to professional misconduct. And so they're not even related to clinical matters some of the times. It is incivility. It could be drug diversion to self or others. It could be that you are supposed to have reported something, a misdemeanor in your state, and did not follow those rules of the board to be a licensee in that state. Sometimes it is related to clinical practice, though, scope of practice, documentation, breach of confidentiality. You asked for an example. We had one nurse that was working in a hospital setting. A pregnant woman came in and had a baby, and this nurse it wasn't even for 5 minutes, peeked into the healthcare record because they thought the person was related to their ex boyfriend. And just that peek of that record caused their employer, the hospital, to report them to the board. That was not a patient assigned to them. They had no reason to be in that record. It was a breach of that patient's confidentiality, even though the nurse may have known them. And the board, they wanted to initially revoke that nurse's license, but through the help of because it was intentional, right? We have to look at the full scope of this case. It was an intentional act. Um, and so how is that going to bear out if the state lets this nurse keep practicing? Are they
Right.
going to do it again? So they weigh, the risks to the those people in the state. They weigh the actions against, is it egregious? Could it be remedied by more teaching and training? And in the end, they decided to put this nurse on probation. But still, they the things that they have to do now to be on probation and to get off that probation are to hand in performance reviews, to be
Um,
supervised for some of their direct clinical care. And so that even meeting those standards is very difficult if you are a nurse under these sanctions trying to work for an employer who may not want to hire or keep a nurse who has these limitations on their practice.
what are some like that one, obviously, other ones that are like, revoke worthy? Does that make sense? Like, what are things that nurses could do where the board is like, this is so egregious
Yeah,
that I'm not like, like that. I could see how initially you would be like, yeah, that would, and then, okay, we can remedy this because, yeah, you know, X, Y, and Z. But I'm curious what other things there could be that the board would view. Now, I know you're not speaking on behalf of the board by any
right.
of nursing boards by any means, but like that you have seen where you're like, oh, they want to like take the license, not just other kinds of sanctions. So are there any others like HIPAA violation I'm hearing? Any other big ones?
Yeah, I mean, for us, so just to put things in context, when we looked at all of the board's outcomes, we saw that the large majority of them are closed with no action, 45%. Let's just start there. It's not all doom and gloom, but that does mean that 55% of the time the board did take action, some sort of action. And in only about 10% of that time, just under 10%, it was a severe action, revocation, suspension, or probation, right? So these are quite rare, these instances. And when we talk about egregious actions, it is against situations where the potential for patient harm is quite high, that the nurse intentionally did something, that the nurse had a total disregard for patient safety policies and procedures, that the nurse did not do something that could be described as a reasonable response.
Okay.
So we have lots of situations where, clinically it might be related to patient abandonment. It could be related to not carrying practitioner orders. It could be related to those cases of drug diversion to self or others that might be more than just a one-time instance, right?
Mhm.
A recurring factor. And so it could be related to patient abuse. We do have claims of either verbal or physical abuse, boundary violations. And so, depending on the set of circumstances surrounding that case, the board could take those actions for egregious behavior.
Yeah, so this is cool. This is quite extreme stuff. So I'm hearing,
Extreme, yes.
after certain things happen, nurses think, oh, I'm going to lose my license if I make an innocent mistake. And that, from what I'm hearing you say, is quite unlikely. While I'm,
Right.
depending on whatever the situation is, but to to say, oh, I missed my rounding, so I'm going to get my license revoked is not proportional to the action, or I guess if that makes sense. Like
Exactly.
we can
Exactly.
bring the temperature of the room down, I guess, a little bit.
Yes. Yes.
Now, here's a quick question I thought of while you were discussing that. If a nurse does something like that HIPAA violation, is a hospital required to notify the board?
Absolutely.
Okay,
Yes. So many times the hospital might be a mandated reporter
I
of
see.
these violations to the board. When we talk about anyone filing a complaint, it could be your employer, it could be your coworker, it could be a neighbor you're giving advice to. Again, that turned out to be either not great advice or they were dissatisfied in some way. The hard thing to digest about some of these board matters is that if a patient or someone wanting to make a complaint doesn't want to go through the process of identifying an attorney, filing a medical malpractice lawsuit, but still through their dissatisfaction wants to have their voice heard, might
Mhm.
file a complaint with the board as a sort of cost effective way of expressing their displeasure with the situation. What they don't realize is that that launches an investigation for the nurse that it might just be dismiss no action because it doesn't really have merit, or the allegations were groundless, because of this small dispute you had with a patient. It doesn't change the fact that you then needed to go in front of the board, provide testimony, tell your side of the story for that to have happened, for it to be dismissed. So even claims that are meritless or groundless still need to have a defense built for them.
And I've heard that anytime you go in front of the board, it is a very serious matter, even if it was someone made a claim as they didn't like you and it's, vindictive and it's not based in any reality and you can prove it's not and you have nothing to hide, you should still have representation. I've heard that that's something like, oh, I just assume since I have nothing to hide, I'm just, well, of course that I would love for that to be reality, but we
Yes.
should have some legal representation from people who are from attorneys who are have experience in professional licensure uh, representation. I had a nurse attorney on maybe a year ago ish who
Yes.
really honed in on you need to have representation and ideally an attorney with experience in these matters.
Yeah. So when we receive notice that one of our nurses has a board complaint against them, we, through our partnership with TANA, the American Association of Nurse Attorneys, we try and connect them with someone in their area, in their state. They are allowed to select their own attorney, so it is not something, but just as a starting point, having that association be an industry partner of NSOs is great because, to your point, as you mentioned, someone who is knowledgeable about healthcare law, knowledgeable about what might be an accepted practice in healthcare for nurses, can speak to the likelihood of something happening, not just from a clinical perspective, but from the legal perspective. So, for all of those reasons, we would recommend a nurse having representation for these board matters. So, not sitting for any sort of interview or responding to the board without consulting an attorney first. And it while it's not a must, it is certainly something they should consider to have them be skilled in clinical care as well as the law.
Now, here's the question, the big question that I think a lot of nurses don't realize. If they have insurance from their hospital, would their hospital insurance cover legal representation in front of their board?
So every employer's policy would be something that they should know and understand of how they're covered by their employer. We have heard at NSO that a lot of employer provided coverage, while it covers you for the malpractice events, may not cover you for these State Board of Nursing matters because your employer might need to be reporting you in the first place. They're not going to then turn around and provide coverage for those matters that they have reported. So again,
and then at the end of the day, the hospital's most important thing is themselves. So if there's a situation where you're one of 5 people named and it's in their best interest for it to be the fault of you fully, like why would,
yeah.
I would assume a hospital to protect its, or any organization to protect its own interests before an individual, whether or not that person has been there for 5 minutes or 20 years, like to assume that your hospital is going to like put you first, I think is a bit naive, personally.
Well, right. So your hospital's policy is there to protect you, right? Your employer provided coverage is there to protect you. But for how long and to what extent, right?
Yeah.
So if the hospital is the sole person making decisions on how the case will resolve, meaning settle or keep going, yes, most likely they will make a business decision about the financial impact of that claim. I think when we poll our nurses, asking them, what was the number one reason you took out a policy, it wasn't just for peace of mind, although that was a number one response, but it was that they wanted to be covered for anything they did outside of their employment, as well as wanted to have an attorney sitting alongside their hospital attorney, working in conjunction with one another to have the best possible outcome for them.
Yeah, that makes so much sense to do that. Like, and I wonder if you work at a hospital and then you leave, and then 1 year and 11 months later, something is filed, but you're no longer employed there. Would you even be covered by then?
Yeah, it depends. I mean, if it depends on what type of coverage your employer has. There's different types of policies, probably for another episode, but occurrence or claims made, and how you were covered under that. But it's okay to ask questions about that policy, just to understand it. You certainly, it's your own personal decision whether or not you want to take out your own policy, and no one has to know you have your own policy, only you. It's really your personal decision to do that. If you feel like you don't want to have any gaps in coverage or exposures that might not be covered because you don't know all of the policy details of your employment's or employer's coverage.
So when you get a job and you're just like, all right, I'm good because my hospital's got insurance.
Yeah.
Probably not such a good, we need to have informed decision making is what I'm hearing you say. And if you decide,
while you're working for your employer, yes, that policy is going to cover you. But if you do any teaching or training or independent contracting at a different facility or volunteering, we see some nurses doing things over the summertime with camps or for their, schools and things like that. You just want to make sure that you're not exposing yourself to risks that your employer coverage won't respond to.
Yeah, I think we can conflate our license with our employment, and that while you're using your license in your employment, they are separate. And if you're saying I'm a nurse and I'm going to volunteer for X, Y, and Z, yeah, you are using your license and it isn't associated with your employer. But I think, especially as a new grad, you can really conflate the two things because you are entering the professional workforce for the first time and trying to understand the lay of the land.
Yeah,
So that's a
yeah.
very helpful reminder, I think, especially for all our newbies out there. Well, this was, I feel we could probably talk for about 4 more hours before I feel like we'd cover this subject fully. But it has been such a pleasure to have you, and your expertise is so helpful. And I think going to be quite reassuring to um, nurses and new nurses and thinking of questions to ask. And hey, wait,
Yeah.
yeah, that is something I should consider when I, decide whether I'm not going to have insurance or just decisions in how you do your practice and whatnot. So I think this has been a really great episode, and I'm very thankful for your time.
I thank you for all your questions. They were great. It's great speaking with you today. So I appreciate you having me on and look forward to our paths crossing again in the future.
Great. Thanks, Jen.
Thank you.
Thank you so much to Jennifer for her time and her expertise. It was great getting that perspective. We've chatted with other nurses, chatted with a couple nurse attorneys actually on the podcast about malpractice insurance for individual nurses. So it's interesting talking to someone who's been in the industry for, a couple dozen years. A lot of great insight there, especially for those of us who are brand new into the profession. You're learning so many things at once, and having a little bit of information about this in your back pocket, I think, is really helpful. So whether or not you decide to get insurance, is a personal decision. You can check and see costs and whether or not the benefit outweighs the risk to you. I personally am someone who's more of a proponent for it. I know there are creative ways that you can protect your assets and things like that. But I don't know that the average bedside nurse who's, that expertise in nursing and not necessarily the legal field, and if you do run into a situation where you are named in a lawsuit, are going to be able to afford and cope with cost and everything. So something definitely to consider. This is also a very personal decision too. Literally no one, not even your employer, your patients, your colleagues, no one needs to know whether or not you have insurance. It can just be something that you have. It's not something that needs to be shared with other people. You're not under any requirement to share that information. It is personal information about you. So keep that in mind. I hope that helps make decision making clearer for people. So again, thanks to Jennifer. As far as things going on with Fresh RN, pay attention for the new toolkit that's going to drop soon, if I haven't already dropped it when this episode releases. I'm actively working on it literally today, after I record this episode. So I'm not exactly sure of the day I'm going to have it live, but it's going to take our most impactful free content, put it all in one spot. So it'll be multiple courses, and I re-recorded and updated my nursing report course. I'm pretty happy with the update. Added more report sheet options and some more things, and have, I think, 3 or 4 ebooks, the EKG cheat sheet, my AFib course that has been doing really well. A lot of you guys really like that AFib with RVR course. I don't know why that surprised me so much, because I looked at some data to see who's getting what, like who's signing up for things and what's resonating. And I was surprised to see how much that AFib with RVR course is really resonating with people. So that's all in there. So we're going to put it all in one spot. Just a nice little package for you. So, our goal here over at Fresh RN is we're really simplifying. So simplifying with one thing with all the free stuff. And then we're going to move to one thing for all of our offerings is going to be in membership. And if for Black Friday this year, what we're going to move to is we will continue to have Black Friday sales. I think that's a routine we're going to stay into, and membership will go on sale just a few times a year. It will always be for sale, but we will discount it multiple times a year. And Black Friday will be the biggest discount that it's available at. So pay attention for that. If you are not on the email list, do me a favor and get on that so you can stay updated on the Black Friday sale. So thank you, nurses, and stay fresh.